You will have the opportunity to ask questions at the end of the session. You can do so by utilizing the chat function throughout the session so you don't forget your question, or you can use the raise hand function during the question and answer at the end of the lecture. Again, please make sure you are muted throughout. We are going to have a number of people on this call, and I don't want anybody to not be able to hear. And now on to the main show. So we are very pleased to welcome Dr. Sarah Morrow, who recently joined the team in Calgary as a professor at the University of Calgary, director of the MS Clinic, and co-lead of the Hotchkiss Brain Institute MS Brain and Mental Health team. She received her medical degree from the University of Calgary and her specialized training in MS in London, Ontario, and Buffalo, New York. She joins us from London, Ontario, where she was an international leader in the field of cognition in MS. She led the MS Clinic, had a successful research program, and established the first and only clinic in Canada focused on cognition in MS. Sarah sits on many committees to better care and research for people living with MS. And without further ado, we will welcome Sarah to begin.
Thanks, Tricia. And thanks everyone for coming tonight. I am going to minimize the picture-in-picture, so I'm not going to be able to see anyone. But of course, Tricia, if you need me, speak up, or you could probably even text me. That might be better because I've got everything on silence. But thank you so much for coming. I am going to give an update on cognition, although it's not going to just be an update, since cognition has not really been a topic that's been talked a lot about in Calgary. I wanted to kind of give some background about it in addition to some updates. It's something we talked about a lot in London when I was there, partly because of this interest I have and the clinic that I established. But I think it's a newer topic, so hopefully I can give you some introductions as well as some updates. So start with making sure I can move my slides. There we go. So here are my disclosures. I'd also like to acknowledge and pay tribute to the traditional territories of the peoples of Treaty 7 located in the heart of Southern Alberta, which include the Blackfoot Confederacy, comprised of the Siksika, Piikani, and Kainai First Nations, the Tsuut'ina First Nation, and Stoney Nakoda, including Chiniki, Bearpaw, and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6. So I wanted to start with this slide, partly because when I was doing some research for a talk I recently gave at Consortium of MS Centers, I came across this paper with this quote, and it really spoke to me when I think about how I communicate with my patients about cognition. And it said, MS is an invalidating disease. So that stopped me for a moment and made me think about, what does that mean? So if you look it up, the Merriam-Webster definition means to make invalid or to weaken or destroy. Another definition of invalid was not valid, which is not helpful, but being without foundation or force, in fact, truth or law. And I think this really speaks to that feeling about people, that feeling I have when I talk to my patients about the cognitive symptoms they're having, because it really is an invisible symptom. So it's an unseen side of MS. And this is just a screenshot from Multiple Sclerosis Trust, which is a website you can go to, where it talks a lot about the fact that invisible symptoms of MS are really becoming the focus of what we are seeing in clinic, what patients are talking about, and what patients are feeling are impacting their day-to-day life the more. So those symptoms that we don't necessarily see visibly, so that use of a cane, for example, but are still having a huge toll on people's quality of life. And I wanted to bring this slide up because I wanted to direct you to this website. If you've not heard of MS in the 21st century before, it's a fantastic collaboration between people living with MS and healthcare practitioners of all stripes, so neurologists, physiotherapists, neuropsychologists, where they come together to create tools and resources for people living with MS, and always include patients in research and decision-making. And so I just wanted to highlight this one talk given by one of my colleagues, Maria Paz, who she talked about her perspective of her invisible symptoms when she's meeting with her neurologist. So the link is up there, just a screenshot. I'd encourage you to take a look, as it's really helpful to give you some of the language that you might need when talking to your neurologist about your symptoms. So why is MS cognitive impairment invisible? So the first study that was actually published looking at cognition in MS was in 1991. So that's not very long ago. Before this, it was not thought that MS affected cognition at all. In this sample, it was people who were in the community, and they looked at 39 people with MS, relapsing MS, the rest were progressive, compared to the people without MS. On average, they've been 14 years since symptom onset. And for those of you who are in the know, poser criteria are old criteria where it took quite a bit of time to make that diagnosis. So now that time since symptom onset would be a more likely time to say from diagnosis, but it gives you the stats there. And on average, people had a college diploma. And 43% of this sample that was randomly selected had cognitive impairment. So this was huge. This was mind-blowing. This was the first time anyone had actually shown that people with MS had cognitive impairment. Studies since that time have found that perhaps that number is higher, especially in hospital-based samples or MS clinics where they tend to be more complicated patients or patients with more disability. The prevalence can be as high as 65%. But this was still a big deal at the time that this study in 1991, not that long ago, showed that cognitive impairment is present in people with MS. And we now know that it's frequently present, even as early as diagnosis. So this is a study done with one of my students where we looked at all newly diagnosed people with MS who had testing within 1 year, and that was standard of care in the clinic in London, Ontario. So we had a very broad sample. And really what I want to do is draw your attention to the left-handed column. The others kind of talk about how many domains are affected or what parts of cognition are affected, which we're going to get into later. But what I wanted to draw your attention to is that left-handed side. So this 0 is the number of people who are not impaired at all. So these are newly diagnosed people. So these are people with MS who have just been diagnosed within the last 12 months, and only 37% of them aren't showing some sort of impairment in cognition. So it shows you how frequent and common this issue is in people with MS. And if you look at it across all spectrums of the type of MS, overall you see just under 50%. And as early as that first episode, so those people who've had one episode suggestive of MS and don't yet have that diagnosis, clinically isolated syndrome, 35% of them are already showing some trouble with their cognition. So this is a big issue with our people living with MS. And one of the reasons it might be invisible is our traditional way of measuring disability in MS is the Expanded Disability Status Scale, or EDSS. And most of the MS patients on the line will have heard of this scale. We use it all the time. It's used in clinical trials, it's used in clinical practice, and it's how we kind of gauge change over time or gauge the level of disability. And as a ballpark, 0 means you complain of no symptoms, I find nothing on your exam, so 0. 1 means some signs, so I might find something like your reflexes are a bit brisker, but otherwise nothing much going on. All the way to 3, which is where we start showing some disability, mostly in terms of how you walk. 3.5 to 5.5 is really limited by how far you can walk without any aid. So how far are you able to walk before you have to rest, before you feel it's unsafe? And then at 6 and above, it's all different measures of mobility based on whether you need a cane to walk, whether you need a walker to walk, whether you need a wheelchair for most of the time, or whether you're fully dependent. So you can see that this EDSS measure is very strongly driven by mobility or physical disability. And so it's not really capturing those invisible symptoms, of which cognition is one of them. And this was shown in a study done by Maria Pio-Amato, who did this fantastic study back in 2002, where she looked at this old definition of MS called benign MS. And we don't use this term anymore. This is one of the reasons why. And so she looked at this term benign MS, and these are people who had little physical disability, so that EDS up on lower score after 15 years of having MS. So these are people we'd be like, oh, you're doing so great. MS has hardly had any effect on you after 15 years. And she looked at a lot of things, but what I want to draw your attention to is the fact that 1/3 of the sample, this right here, were cognitively impaired. So that meant that of these people who we as neurologists were saying, you are doing great, you are having no problems for your MS, you are living a normal life, 1/3 of them had enough cognitive impairment that it was affecting their quality of life. So this really changed how we talked about MS, and it's one of the reasons we no longer use this benign MS term. And if you go back to the EDSS, I meant to have the slides in a different order, I apologize. We did a study recently where we looked at what happened if you included cognition, as well as fatigue, another invisible symptom, when you scored the EDSS. And you can see in the orange, that's the way you traditionally score it, which is based on physical disability. And the green is what happened if you included measures of cognition and fatigue when you're measuring that level of disability. And suddenly you can see that trend is towards higher levels of disability. So it means when we're using this EDSS, as we usually do in clinic, we may be missing the level of disability our patients are experiencing, as well as perhaps missing some symptoms that we could address by not talking about their cognition and their fatigue. So why is cognition a new topic? And I always like to bring this up because in some ways it wasn't. In some ways we kind of ignored it as a medical practice. So Charcot is a famous neurologist. He talked about a lot of different things. There's a lot of things named after him. So way back in 1877, he mentioned that people with MS had marked enfeeblement of the memory, conceptions are formed slowly, and intellectual and emotional faculties are blunted in their entirety. Now, I disagree with that last part of the statement, which we'll get to later, but it does tell us that an astute neurologist in the past did notice that people with MS were experiencing trouble with their memory and their thinking or their cognition. So is there maybe a neurological bias? And I have to say, I think there might have been. We are trained and we think of cognition when we think of Alzheimer's or dementias, where people have that slow worsening problem with their cognition, meaning they don't recognize people, they don't know how to use objects, they forget how to do things like dress themselves or use objects like forks and knives or pens. Whereas in MS, intellectual functions not affected and language skills, a big part of Alzheimer's, remain intact. It's actually one of the things I tell my MS patients is you're still the same smart person you used to be. It doesn't affect intelligence. It just may affect other parts of your cognition. And yet that is very different from how we're trained in neurology when we're doing our neurology residency. And there was a really cool study of Toronto done in 2015, where they looked at 97 people who were sent to get cognitive testing because for some reason, someone thought they had trouble with their cognition. It could have been the patient, it could have been their family member, it could have been the neurologist, it could have been just random because someone said, hey, I wouldn't mind getting my cognition testing. And in this study, the investigators asked the neurologist when they were referring the patients, do you think this person has cognitive impairment? And out of that, they were just as accurate as flipping a coin, whether the person was impaired or not. So when they looked at the 97 people, just under half of them were impaired. But the neurologists were no better than flipping a coin when they were trying to decide who had cognitive impairment and who did not, which means that we are not doing a good job of identifying our patients, talking about it, getting them tested, and then intervening when we can. So I'm going to just flip a little bit and talk about what I mean when I'm talking about cognition. I just wanted to introduce why this is a new topic and why I think it's important. But now let's kind of talk about how cognition is affected in MS. So what is cognition? So if you look up in the dictionary, it says mental processes in Webster. If you look at the Oxford Dictionary, it says the faculty of knowing or perceiving things. It really has to do with those processes where we understand our environment, we interact with our environment, and how we plan around environment. So it's our ability to learn, our ability to remember things, our ability to plan and organize and problem solve, our ability to focus on today's talk and shift your attention as needed if your phone goes off or the phone rings or alarm goes off saying that, the coffee you put in the microwave is finished being microwaved. It's our ability to understand language and to perceive our environment properly, as well as to do calculations. So that's just an overview of what cognition is in general. But then how does cognitive impairment present in MS? So as I alluded to, it's not like Alzheimer's. We don't lose our ability with our language. We don't lose our ability with how to use objects. We don't forget who people are. We just forget things overall. So we have trouble with our memory. We have trouble with our attention, information processing speed, executive function or problem solving, as well as visual spatial dysfunction. And I'm going to go through each of these individually. Again, it's really important. I want to emphasize that MS does not affect language, it does not affect intelligence, and it's not like Alzheimer's. So memory, this is the most commonly affected domain in people with MS. So when you think about it, there's several components of memory, and this is just broken down very simply. So there's encoding. So when someone tells you something and say, don't forget you have a doctor's appointment tomorrow at noon, you have to get that information in. You have to actually encode it. Then you have to consolidate it. You have to transfer it from your working memory into long-term storage. So you actually have to lay it down as a memory. thereafter, you actually have to be able to retrieve it, right? It's not just you have to lay it down, you have to be able to, when the time comes, to retrieve that memory. And there's kind of two different ways you can retrieve things, either free memory recall or recognition. And I use the example that though the difference between the two is perhaps writing an essay versus a multiple choice question. Do you actually have to come up with it spontaneously, or do you just have to choose from the options given to you? And people with MS tend to have more trouble with that acquisition of information. So they have less trouble retrieving it once it's laid down, but they have trouble with getting it in and then laying it down as a memory. This is the most frequent complaint I see in clinic. And I think that's partly because it's the most easily recognized in day-to-day. So we all know if we've forgotten something because someone will remind us that we forgot to pick up someone from school, or we forgot to pay that bill, or we forgot that appointment, or we forgot that commitment. Subjectively, I will see people telling me that they're having trouble learning or recalling new information provided to them in a meeting, or that they walk into a room and forget why they went in the room. They know they had a conversation with you yesterday, but don't remember what was said. And then, of course, forgetting appointments and planned tasks. Processing speed and attention are another two areas that are commonly affected, and they're almost two sides of the same coin. So information processing speed is just like it sounds. It's that ability to take in information and use it quickly and efficiently. So this is actually the most frequent impairment when we do cognitive testing on people with MS. This is the one we see that's most commonly affected. So I often hear people say, I could do everything I used to do, I just need more time. Or I can do things, I just can't deal with interruptions. So I can work on my task, but if the phone rings, I have trouble getting back on my task after I answered the phone, as well as remembering what they told me on the phone. So it leads to a lot of decreased productivity as well as slowness to respond to information. On the flip side, attention is that ability to focus on one aspect of the information and ward out distractors. So it's kind of that old example of that cocktail party where you could focus on that one person talking to you and block out all that extraneous noise from all the other people around you. So you have trouble with that focus and you have trouble with that divided attention. And then these three all interplay. So if you have trouble processing information, you're not going to be able to encode it and lay it down as a memory. And then if you never lay it down as a memory, you're not going to be able to retrieve it. And because of that, it leads to trouble with poor attention and concentration, because then you really have a hard time if you're not able to focus on the task at hand, and you have a lot of less mental flexibility. So dealing with task interruptions or multiple conversations going on at the same time. So complex reasoning and executive function is something that's less likely to be affected, but when it is affected, I do find it's one of the ones that can be the most debilitating. So it's that ability to kind of abstract reason, kind of think about things and be flexible about it, manipulate ideas in your head, plan or organize things. So one example I have of one of my patients was she and her husband used to go away frequently and once a month, just away on a weekend. And she didn't want to do that anymore. And her husband's like, I don't know what's going on. She doesn't want to do it. And when we talked about it, she said, well, I just don't know how to pack. I open the suitcase and I look at it and I think, I just don't know what to put in there. I don't know what to do. And she had trouble thinking about, well, what are we going to do for the weekend? What is the weather going to be like? What should we do? And so one of the things we came up with is that her husband would say, okay, so we're going to arrive Friday and we're going to go out for a fancy dinner Saturday. So make sure you bring something for fancy dinner. And we're going to go hiking on Saturday afternoon. So we need to bring your hiking clothes. And then Sunday, make sure you bring comfortable clothes because we're going to be having a long drive going somewhere else. So that allowed her to not have to plan it, but it allowed her to do the activities she liked because she just was having trouble with that planning and organizing. So we'll see this a lot when people get frustrated because they hit a wall. They see something and they're like, I just don't know how to do this. And so often it's become frustrated and overwhelmed and just don't end up doing it. So that's a kind of an example of complex reasoning or executive function. Visual perception, again, is less frequently involved, but it's one that I'm finding has a big impact on people's day-to-day life. So it's that ability to interpret distances and shapes in your environment. And what I'm finding is it really leads to trouble with driving the most. So being able to judge that distance when you should stop when a red light is coming up, or how far you should park behind, how far you should stop behind that person who stopped in front of you at a red light or a stop sign. Leads to trouble with checking blind spots because it's hard to actually perceive things quickly in that way. Trouble with judging distances when parking the car. So, spacing yourself appropriately and backing up into spaces becomes more difficult. So kind of that gives you an idea of what that visual perception is. And then verbal fluency. So again, MS does not affect language. It's not that you don't remember that it's an apple or you don't remember what that person's name is, but you have trouble with retrieving the word. So it's, I know that guy, I used to work with him 10 years ago. We used to eat lunch at we had the same lunch break. I just can't remember his name. And then you know his name. He says, oh, I'm Gord. And you're like, oh, yes, Gord, of course I remember who you are. And you can have a conversation with him, but you just have trouble with that word retrieval. Again, it's infrequently affected, but often people complain about it. And what I found in my clinic and in my research is that people who have this problem tend to more have trouble with processing speed. So that ability to process that information quickly to bring Gord's name to the tip of your tongue. So that's kind of how cognition can present in people with MS. And so how can we help people with MS who are living with cognitive impairment? So I'm going to go through most of these with the exception of driving assessment and rehabilitation, because that's a whole other topic. But these are all areas where we can help. We can intervene before it becomes a trouble at work. We can look at depression and anxiety symptoms. We can validate what people are experiencing and help them navigate how to change their day-to-day life so that they can continue to live to the best of their ability. We can look at perhaps how other things might be affecting their cognition. And then it might even tell us if their disease-modifying therapy is not working. So we're going to go through all of those minus the driving. So why is screening and follow-up necessary in cognition? So this is something that I think is extremely important, and I'm a big advocate of it. And this comes to validating what you're feeling. So if you think about it, all of us start with an idea of where our cognition is and where our skills are. So all of us have different levels of where we start. And that's partly genetics, it's partly intelligence, it's partly what you've been exposed to, partly it's education. But sometimes you may notice a change. So perhaps you're that person in red where you start at a higher level of baseline and you notice a decrease in your day-to-day life. But I do your testing and I say, well, you're normal. Because when I look at the bell curve and I compare you to a normal population, you're normal. Well, that doesn't really help you because what you're noticing is real and I'm telling you it's not real. And that doesn't validate how you're feeling. It actually leads to that invalidation we were talking about before. So because changes can happen over time, it's really important to get a sense of where things are so that we can measure change over time. And so I use the example, and most MS patients who are on the line will understand this, is one of the reasons we do MRIs frequently. Because if I want to know what's new, I better know what was on that first MRI. If I want to know if you have a new lesion since the last MRI, I need to have that last MRI to make that change. So I can't tell what's new if I don't know what was at baseline. So it's the same with cognition. And so if we're not validating what our patients are feeling and saying, yes, you're still within normal limits, but you have had a decrease in your information processing speed, and that's why you're struggling to meet your deadlines at work. If we aren't able to get that information, we're not able to help our patients as best as we can. And this is really important in employment. So two invisible symptoms, cognition and fatigue, are the most common reason why people with MS either leave the workforce altogether or reduce their hours. So if you look at the graph on the left, this is just looking at scores on a processing speed test. And a higher score means your processing speed is better. And if you look at the rate of employment based on the processing speed score, you can see there's a significant decrease in those who have a lower score and in terms of the rate of employment. So this has a big deal in terms of patients' ability to earn a living and contribute to society. We looked at this a few years ago, looking at predicting change over time. So what we looked at is people who had stable employment over time. So that's the orange group, and those who had a decrease in their employment over time, and that's the blue group. Conservative meant people who went from fully employed, working full-time, to completely unemployed, getting some sort of disability benefits. And the liberal was any change. So they may have gone from full-time to part-time. They may have gone from part-time to unemployed. They may have just had reduced hours or reduced responsibilities. But in all those cases, you can see that there's a decrease in the performance on their tests on measures of memory, that's the first two, and processing speed, which are the second two. So those are the biggest predictors of people who went from employed to unemployed or had reduced hours or reduced responsibilities, was due to their cognitive change over time. And what's even more important recently is this idea of absenteeism and presenteeism. So absenteeism is something I think we can all easily understand. So it's when you're actually absent from work. So it's the days you don't actually go to work because of your MS. Presenteeism is those days when you get to work and you're not able to work to the best of your ability, because of your health issues. So it might be because of your information processing speed that you take longer to do the same tasks. So you aren't able to complete the same amount of work in the same amount of time. Or you're not able, because of your fatigue, to do cognitively demanding tasks in the afternoon. And this is something that is an area that we're really exploring now, because we realize it's actually just as important to look at presenteeism, because it affects people's value of their self and the value of how they're contributing to their work, and also can lead to unemployment, because if you're not performing at the level it's expected of you, that can affect badly and can lead to negative consequences. So it's something that's just as important to look into. And this is one area that I thought was really important to bring up, because I think most of us have a bias of saying that we should not be asking for work accommodations, especially with invisible symptoms. And I always bring this up with my patients, and I say, you know, if you use a cane or wheelchair, no one would expect you to use the stairs. Everyone would say, oh yes, of course, you need to take the elevator to get to work. No one would ever expect you to take the stairs. But when they can't see that you have bladder urgency, so you need to be near a bathroom, or that it takes you longer to process information, or you need a quiet work environment because you have trouble with processing and attention, then they're not going to understand that you need to use that elevator. So we need to ask for work accommodations, and we need to do it before it becomes a problem. And most of us are a little bit worried about that, because we worry about the judgment. If we ask for work accommodations, that we might be judged at work. But this study that was just published in 2022, which I thought was really well done, showed that actually the quality of life of people who would ask for work accommodations was higher than those who had not, because they felt more validated. So they weren't invalidated again. They felt more validated and felt that they were able to contribute to their workplace better. And they were not feeling like they were hiding something from work. And some simple things that you can look at: working from home to manage your fatigue on certain days, using memory aids like being able to record meetings, giving extra time to complete tasks, preferential parking closer to the door so you don't have to walk as far and you can save your energy for work. And then, of course, air conditioning, which I'm learning I may not need that as much here in Calgary as I did in London, Ontario, but we all know that heat can negatively affect people with MS. So it's important to keep that in mind as well, that that might be an accommodation that could be made at work. So I want to flip into now, what can we do to help with cognition? So we've talked a little bit about how it can affect things negatively, but how we can ask for help, but also what can we do in the clinic with our patients to help. So first of all, I'm going to talk about how we can treat other things that can worsen cognition. I'm going to talk a little bit about avoiding medications that can worsen cognition. I'm going to talk a little bit about preserving cognitive function, and then hopefully talking about how we may in the future be able to treat cognitive impairment directly. So I guess that is the spoiler alert, is we don't currently have any treatments that directly improve cognition, but we have lots of ways that we can help. So depression and anxiety, common in people with MS. 50% of people with MS will experience depression and anxiety at some point in their life. In people without MS, we know depression worsens working memory, processing speed, attention, and executive function. So I'm sure that all sounds familiar to you now. So it only makes sense that this may affect people with MS. And the idea behind that is that depression kind of reduces your ability to deal with other things. You have less capacity to deal with other things. If there's a lot of your brain function or your rumination, other things thinking about the depressive symptoms, you have less resources available for other tasks. But it hasn't really been looked at in people with MS. So we thought, why don't we do that? So we looked at a sample of about 150 people with MS, and we used a measure of depression and anxiety called the HATS. And we looked at cognitive performance in those who were normal on depression versus abnormal on depression, and normal on cognition, on anxiety versus those who are abnormal on anxiety. So on the left-hand side, we're looking at depression. On the right-hand side, we're looking at anxiety. And you can see pretty consistently that those who scored in the positive range for depression performed worse on cognitive tests. And those who scored positive for anxiety also scored worse on cognitive tests. Now, the one thing we don't have is that chicken and egg. We don't have that causation. Unfortunately, that's not something that's been well studied. I don't need to go into that right now, but it is something that I think should be looked at. Certainly, it is something that's easily treatable. So if we have depression and anxiety and it's affecting cognition, we have excellent treatments for depression and anxiety, and thus treating them should lead to improved cognition. Sleep. So half of people with MS in this study reported trouble with their sleep. So they woke up in the morning not feeling rested. And it's important to keep in mind that sleepiness is not the same as fatigue. So sleepiness is that I could fall asleep anywhere, I feel exhausted. Whereas that fatigue is that feeling of just overwhelmed body fatigue, where a lot of patients describe it to me as just feeling like you're walking through deep water all the time, or everything feels heavy, or everything just feels like a chore. You're not sleepy, you're fatigued. So that's important to keep in mind. And physical disability, again, did not correlate with fatigue or sleepiness scales. So even though you may have low physical disability, you could still have trouble with your sleep and your fatigue. And most of the moms in the room will know that those nights you were up breastfeeding or up all night feeding, the next day when you didn't sleep, you did not function well. And so it only makes sense that if you're already experiencing fatigue and you're already experiencing cognitive impairment, if you are then not sleeping well, you're going to function poorly the next day. And in this study, they found 1/3 of patients had obstructive sleep apnea, and almost all of them had some sort of sleep disturbance. So this is something, if you're struggling during the day, addressing your sleep issue may also improve your cognition. Another is looking at other medications that we commonly use that could affect cognition. So anticholinergic medications are commonly used to treat bladder symptoms. So oxybutynin and tolterodine are recommended as first-line therapy for bladder in MS, and they are both anticholinergic medications. We know they act at the bladder, but we also know they cross into the brain across that blood-brain barrier, and they can act directly on the brain. Studies have looked at older people, and this is not my definition, this is the epidemiology definition of older people is greater than 65. And we know those who are on anticholinergic medications have worse cognition, but it was never really studied in people with MS. So my group thought, let's see. So I put up this slide, although the important part is on the right, which shows that anticholinergic medications in MS did affect their cognition. But I wanted to put up the other side because I think sometimes outside of medicine, we don't realize how much work it takes into running a trial. So it just gives you an idea here of us trying to recruit for this study, of how hard it is to keep people in the study, and then so get them in the study and then keep them in the study enough such that we have the large enough numbers to do the analysis. So just want to put that on the side as a shout out to my other researchers and myself about how much work it actually takes to get that one slide on the right to say anticholinergic medications affect cognition. And so if it is something you're worried about and you're having trouble with your cognition, talk to your neurologist about trying a different bladder medication. There are several other classes of bladder medication that don't affect cognition, and you may be protecting your cognition from being affected by changing the medication. Cannabis. So this is a big issue in Canada because it's legal. So people use it both for medical reasons, and people also use it recreationally. And so on the left, you can see just a couple studies. I just want to use a couple of examples that show that people who use cannabis compared to people who do not use cannabis have lower measures of cognition objectively. But I also know that sometimes it's the best thing for your condition. So like any other medication, you just need to keep in mind that this is a side effect, and you need to decide for yourself, is the side effect worth the benefit I'm getting? As long as you're aware of that. What's reassuring is this really neat study done out of Toronto by Anthony Feinstein, who looked at people who were taking cannabis regularly, and he enrolled them in the study and said, hey, how about half of you stop it, half of you don't? And that was randomly assigned, so it wasn't biased towards people who were maybe thinking of stopping it. And what he did is he looked at them 30 days later and looked at their cognition. And those who stopped cannabis improved on all cognitive tests, whereas those who continue to use cannabis daily continue to have cognitive impairment. So it does tell us that it's something that's reversible, but it's something to talk about and decide if this is something that is for you, or whether there's something else that might help your symptoms that may not cause trouble with your cognition, knowing that it's reversible. The trouble with cannabis, though, is it's really two drugs combined. So there's THC, which is the main psychoactive component that gives the high and also gives the side effects, the sedation, and the intoxication. Whereas CBD is less well understood because any natural THC products, so any plants that are grown, are a combination of the two. And pretty much all THC products have some CBD in it because THC acts at CBD receptors. So it doesn't work unless there's CBD available in the drug itself. So less is really understood about CBD, but a lot of patients prefer using it because it doesn't give them that high. So they say, I don't want to be high, I just want to sleep, or I don't want to be high, I just want my pain to go away. So there's a few small studies that have said that maybe CBD doesn't affect cognition, but is not really known. So this is something that I find of interest because I have so many patients who are taking this and I want to know, can I advise them whether THC is the issue or if CBD is the issue? So we got a grant through the MS Society of Canada, now called MS Canada, where we're going to be looking at people who take THC versus taking CBD and see if it affects their cognition. So again, in terms of trial design, it's really hard to get it through an ethics board when I say, hey, ethics board, I want to give people a drug that might worsen their cognition. That doesn't fly. So what we did instead with my co-investigators, urologist, Dr. Blaine Welk, is we thought, well, there's a bit of equipoise in terms of whether THC or CBD helps bladder symptoms. It's another common invisible symptom that people use cannabis for. So we thought, well, why don't we take people who have a bladder issue and need something? So we're not primarily trying to harm them. We're actually primarily trying to help them. So we can randomize them to get THC or CBD, look at if it helps their bladder, and then secondarily see if it helps their cognition. So part of the problem with doing this study is that there's no literature on how to dose THC for the bladder or how much THC is what actually might lead to cognitive impairment. It's all been just users or non-users. Same with the CBD, we don't know how to do it. We also don't know if we'll be able to hide it from our participants. You know, THC has clear side effects. So how do we conceal them from knowing what they're taking? So before we jump into our big study, we get a small study where we're going to just use small doses, bring them up slowly, and try to conceal it and try to see if we can figure out what dose. So we're going to bring them up over 10 weeks to what we think would be a good dose, 25 milligrams of THC or 50 milligrams of CBD. Keep it on for 5 weeks and then test their bladder and their cognition. And hopefully from that, be able to get a bigger, larger study where we can try to answer the question more effectively. So this is a very small study, only 30 patients. But I think it's really exciting to be able to look into this and see how it can both help bladder as well as minimize harm with cognition. Another way you can try to maintain your cognitive function is prevent relapses. So way back when, even in the 1990s and into the 2000s, the general thought was, okay, MS affects cognition, but it's really not to do with that inflammatory part of the disease, those new lesions that happen and cause relapses. That's a whole other ballgame. There's something else causing it. We don't know what it is, but the drugs that we use don't have any effect. And we felt that that was incorrect. So we looked at a database where people who had relapses were being tested for their cognition every month because they were on a drug that was being administered every month. And so we took a bunch of people with relapses and compared them to those without. So on the right-hand side here, you can see that the people who had a relapse, so that's the time between pre and post, so they were tested for their cognition when they got their drug, and then they're tested for their cognition when they got the drug, and they had a relapse in between. You can see that they decreased on their measure of processing speed and then bounced back in that same pattern you would see with that relapsing remitting course we see with MS. In contrast, the people who did not have a relapse continue to show some slight practice effect on their test overall. So this was the first study that showed that relapses can affect cognition. We looked at that a bit more, and more recently, we just published this October 2023, where we looked at actually trying to see if there are people who are having relapses where it does not affect their physical function and just affects their cognition. And we were able to show that there was a cohort of people who they had a decrease on their measure of processing speed and had no decrease in their physical problem. Similar in the same pattern, you can see here, the people who were in the solid line, these are people who had physical relapses, and they had a similar pattern of decrease in their processing speed as to those who did not have physical symptoms. So we now have evidence that disease-modifying therapies may prevent cognitive impairment because you can prevent relapses and prevent accumulation of cognitive impairment over time. Both the cognitive impairment you might see with those physical relapses, as well as relapses that may occur without any physical function. And for me, as a clinician who's really interested in cognition, as a clinician interested in cognition, That's almost the holy grail, is being able to find those cognitive relapses and treat them, because my patients are going to call me if they go blind in an eye. They're going to call me if they suddenly have trouble walking, but they're not going to call me if they say, I'm not good at my job anymore. I don't know what it was just this week. This last 2 weeks, I just couldn't do my job. And then it got better. That's the same pattern we see with relapses. And yet often people aren't coming to our attention. And so we're missing that relapse. We're missing the ability to intervene and change their treatment such that we can treat them better. Another way that we can look at preserving cognitive function is building up cognitive reserve. So this is actually from the Alzheimer's literature, and I apologize, I should have fixed my slide here before I presented it, but cognitive reserve is basically ways to compensate for damage. So in the Alzheimer's literature, what they found is at autopsy, they would find the pathology associated with Alzheimer's, and yet those people did not have Alzheimer's during life. And what they found is people with higher reserve, so people with larger brain volume, which is not necessarily something we can change, but those who had higher cognitive reserve, such that they had built up that reserve prior to having the pathology affect them, were more able to compensate for it and weren't showing the same effects of that pathology that they were seeing at autopsy. And we're seeing that this is a thing in MS as well. So kind of proxies of cognitive reserve is those who have higher education levels, those who have larger vocabulary, those who have higher intellectual demands in their occupation, but also those who have higher degrees of intellectual engagement. So playing intellectual games, reading newspapers, and those who have higher degrees of social engagement. So you're using that, processing speed, you're using that executive function. Those are all things that we can do to boost our own cognitive reserve. So those is kind of like exercising, right? None of us would go and run a marathon without preparing for it. So why aren't we preparing our mind for what may happen in the future? We want to build up that reserve and to be able to deal with what may come in the future. But before I get to that, this was another study that showed that those who had premorbid cognitive leisure, meaning they were doing a lot of things that were cognitively demanding in their leisure time, they had lower measures of impairment. Sorry, I'm not saying that way. Those who had higher cognitive leisurely demanding tasks, so those who were doing it on their own, had less cognitive impairment once they developed MS. And when you follow that over time, they were less likely to develop cognitive impairment in the future. So it tells us that these are preventative measures we can do in order to build up our reserve and prevent cognitive impairment in the future or slow it down. But again, there's still so much we have to learn. So Alzheimer's disease, one of the biggest cognitive reserve markers is multilingualism. And not just those who have chosen to learn a second language, but those who have been forced to learn a second language because of immigration or other reasons. It was a really landmark study that it kind of changed everyone's mind, because it was always thought that, well, multilingualism is those who, they already have that higher intellectual drive, so they're the ones who are learning the second language. But it was found just as much as those who were children or adults who moved to somewhere else where they were forced to learn another language. And they noticed that it delayed the onset of symptoms of Alzheimer's by 4 years. And if you looked at how much it was affecting their brain, those who had still had more effects on their brain had less cognitive impairment when you use that multilingualism, more than one language, as a mediator. This has not been looked at in MS. So we thought, well, let's look at this, because this might be an easy intervention. We can just prescribe Duolingo to all our patients. And this was just published earlier this year. We looked at people who came to our MS clinic. It was part of our routine care to ask how many fluent languages they spoke. And so we created groups that were unilingual versus multilingual. And then we looked at tests. We looked at all the tests we do, but we focused in on those that would be less likely to be affected by language. So visual, memory, and processing speed. So in our group, not surprising, in London, Ontario, is most of our patients were unilingual, but we did have a pretty significant group of multilingual. We luckily had a large sample. So even though it was only 17%, we had over 100 people who had more than one language. And most of them were bilingual, but there were a few who were fluent in more than one language. The sad part is that there was no difference on any of the tests. So when you looked at visual memory, immediate recall, visual memory, delayed recall. They scored just about the same whether they spoke one or multiple languages. This was the same when we looked at processing speed, when we looked at executive function, when we looked at visual spatial memory. And this is important, although in some ways it was very disappointing. We really thought it was going to be positive. I have to say that was my bias going into doing this study. But it tells us that there's still so much we need to know. And in some ways it makes sense. I've been emphasizing how MS is not Alzheimer's, and MS does not affect language. So perhaps there's something about multilingualism that has to do with Alzheimer's pathology that doesn't affect people with MS. And so it really makes us as researchers think about what we should be doing and what we should be looking at next in order to help our patients in terms of cognitive reserve. Okay, so my last little bit here is a push, because I did say that, spoiler alert, there are no treatments. We don't have anything that improves cognition. We just have things that we hope prevent cognitive impairment with cognitive reserve and disease-modifying therapies by preventing relapses, as well as treating other things can affect cognition like depression, anxiety, and other medications like cannabis and anticholinergics. But are there really no treatments? I could talk about this for an hour on its own. But in the interest of time, I'm going to focus on one treatment, which I think has a lot of promise. So we did a small study looking at Adderall XR, which is on the market for attention deficit disorder. We did a very small pre-post dose study, meaning we tested their cognition, and then we gave them either a placebo, 5 milligrams or 10 milligrams of Adderall XR, and then tested them later. And what's really important here is, if you've heard of Adderall, most of you have heard of Adderall IR, just called Adderall. IR means immediate release. XR means extended release. So IR, people take it, it's released into the bloodstream within 30 minutes, and they can get a whoosh or a high, which is why it can lead to abuse. But it's also why it can help with focus very quickly. With this drug, it's extended release, so it takes 7 hours to peak. So which is why we did that. And so what we found is that higher dose significantly improved their performance on the test compared to those who did not take it, or took a placebo, or those who took the smaller dose. So based on this, the MS Society of Canada, or MS Canada, which is now called MS Canada, gave us funds to run a large multi-center trial across Canada. So we originally had 5 sites, but unfortunately 1 site dropped out after we got the funding. So we were the lead site in London, and we had a site in Toronto, Edmonton, and Halifax. And what we're looking at is 12 weeks of either being on placebo, 10 milligrams of Adderall XR, or 20 milligrams of Adderall XR. And what we're looking at is measures of processing speed, that's our primary outcome, measures of memory, both visual and spatial, but we're also looking at questionnaires and adverse events, because of course it may be one thing if it helps, but if it's harmful or has lots of side effects or is not tolerable, that's just as important. So we will be done recruiting this study in December of 2023. Our goal was to get 150 patients across all 4 sites. And so hopefully at my next talk, I'll be able to tell you if we have shown that this drug helps. So stay tuned. So that is my whirlwind tour of cognition and MS, starting with why is a new topic, how it presents in people with MS, as well as some ways that we can try to help you, or you can help your loved ones, or we as neurologists can help with cognition. So it's important to remember it's common, it's invisible, and yet has a significant impact on the life of people with MS. And it's not a dementia. So even though we don't yet have a treatment, there are many ways that we can preserve as well as improve cognitive function by addressing other things that might be affecting your life, try to prevent relapses, and build your cognitive reserve. So I am going to stop sharing my screen so that I can hopefully take some questions.
Thank you very much, Sarah. I'm going to stop the recording so everyone feels free to ask whatever questions they would like. So I'll stop that first.